Thanks for joining. We're going to get started now. Just a reminder, 30 minutes, one question, one follow-up. Today we have Dr. Willams and Dr. Allen here today, so I'll turn it over to them for some brief remarks.
Good afternoon. It's Thursday, and Thursday we do a couple things. One is we look back over the week and see what's gone on. We sort of look ahead on the weekend to see what we should be expecting. And quite often we have the privilege of having special guests and people here to present. And so today we got Dr. Vanessa Allen, Chief of Microbiology and Laboratory Science at Public Health Ontario Laboratory. And you've seen her before, but we're asked her to come today, and I'll talk about in a moment as she's going to talk, I will say that she's going to speak on, we did the variants last time, almost like our 101, 201. And today she's going to talk about what we call a point prevalence study, a variance in Ontario study. And she'll give the details of that and when I introduce her partway through. But first I'm going to talk about some general numbers and where we're doing, and then I'm going to ask Dr. Allen to talk about our point prevalence study and what does that mean and how that impacts our knowledge base utilizing the new technology that Dr. Allen and team had developed, first in North America, I think, but maybe I'm wrong, I like to oversell it, but we're first in Canada, that's for sure, and so I'll let her cover those details. So, where are we at since Monday? When we last spoke, we had reported an additional 3,480 cases and have happened, and another 169 people have lost their lives due to COVID. And of course, those are real life events there. We had 88 of those deaths reported in today's numbers. Some of them were numbers from previously added into that total there, and so that was a data correction on the deaths in particular. But again, they have occurred, they did occur, they affected families and family members, and of course our condolences goes out to those people and their family members in this time. So with that in mind, we had low cases numbers reported. We knew that 745 was reported on Tuesday. That was a data shifting over of our systems with Toronto coming online with our CCM system, which now everyone in the province is on the same system. And there's a lot of work involved in that, and that was a data entry issue there. We were waiting to see if the fluctuations would occur. Yesterday's number was 1,172, and that was pretty consistent with what we had seen in the laboratory data positivity. So we didn't see that was a data entry correction, but it was a low number of tests over the weekend, which we often see a dip that often is reported on Tuesday. And now the numbers have picked back up again with the volume up, and we saw reported 1,563. And that seems to be where we've been hovering around this 1,500 or just below that at this time, which was excellent because we're seeing this downward trend. So our 7-day current average was 1,600. That's down from 2,128 the week before and 2,751 2 weeks ago. So you can see this steady coming down. And this is consistent in there. And you say that our numbers there, when we look at it, we were asked yesterday when we did the school, they said, well, it seems like your numbers now are even higher than they were before the school break in December. That's not correct. I'd like to correct that. The last time we were at around 1,427 was back in mid-November. So this is a significant drop in there, and that's why we felt it was okay to have our schools open up a stage phase as the Minister of Education had announced yesterday. And so that's encouraging. But at the same time, we're not out of the woods on these issues. I'll talk about that in a moment. Our testing volumes, even compared to the fall, were still higher. And we did yesterday over 52,000 tests in that, and coming up over 64,467 are pending, and our positivity rate for the first time in a long time has dropped below 3% down to 2.6. This is the first time we've been below 3 since October the 30th, 2020. So these are significant markers showing the impact and effectiveness of our public health measures, namely the closure and Boxing Day, added to the stay-at-home order, which has given us evidence of the impact of it and how important it is to get this number down. How does that affect our other one? Because remember, our purpose in this was to decrease morbidity and mortality, mostly the impact on our healthcare system, which is under quite strong duress and pressure throughout the early parts of January. And we see that hospitalizations have come down. They're at 1,101 at the moment. And our ICU admissions, which remember we were up in the low 400s, up to 420. Just a few weeks ago, we were down to 323. Better, but we're still not where we need to be. We need to get that number down well under 250 if we can, ideally getting back down to under 150 to impact our healthcare system and to let it get back to dealing with the normal elective procedures and other aspects there. So, looking better. We're not there yet. Everybody's doing great. We're doing fantastic on that, but we have to stay the course. And now with schools open, we're going to watch that and monitor that very carefully. And we are doing our enhanced methods of testing, as Minister Lecce had alluded to, and in public health also. We're asking our medical officers' help to utilize whatever testing methods they need to do to follow up on cases, potential cases, symptomatic children, so-called mild symptomatic children sometimes, even polysymptomatic. That's a fancy term for it's a symptom maybe, but the parents aren't sure. We want to make sure we can get a way that the parents can say, I'd like to have my child tested. In fact, could we have our family tested? But we can't wait for a long time to do it. How can you make that work? So we're asking our health units to set that up to deal with as good a quality surveillance in and around cases, potential cases in the school systems before they get to the school, as we have done already in some cases, such as in Ottawa. On the other side, we're also reporting on our vaccine program. We know we're waiting for the orders to pick back up again. We know that's happening more on the week of the 15th when we get back up with Pfizer, and we're getting the renewal on others with the Moderna. And of course, there's new ones coming online. We're looking at when they might be coming forward and understanding what they mean, how that impacts us. So we're waiting for all those approvals. At the same time, we have put in place, because people have questions about the vaccine, we have, as we do with all our vaccines, and we have a special one here for this one, or our adverse event follow-up. So the so-called AEFIS, that's a fancy term. You'll hear people talk about AFIS. We'll try not to use the acronym too much. And saying their adverse event reporting, which we're asking everyone to do very diligently. And so far, with over nearly 340,000 vaccinations given in Ontario, up to the current time, we have 193 adverse events. 191 of those were mild, such as local pain, itchiness, feeling a bit unwell for a period of time. In there, we've had one event managed with anaphylaxis, and one other was severe, but no details have come on that one there. But both were hospitalized and have fully recovered. So this tells you that overall, our experience has been very safe at this time, but doesn't mean we're not going to keep watching. We're going to keep looking for that. Most, I said, were skin reactions, 31%, some local pain and swelling, about 21%. So there we are with the vaccination, and we're waiting for General Hillier and the whole team. When the vaccines start flowing again, which we hear they are, then we'll get back on pace. We're covering as many people as we can with our high priorities, and they'll be ready to, as the general would say, march ahead in big strides. I'll try and use the military terms. Apologies to General Hillier, and get this back on track. We have also our variants, and that's what we're going to talk about now. We have confirmed right now, through the hard work of Dr. Allen and other team members, 153 confirmed cases of variants in Ontario. 152 have been identified as the so-called UK variant, and Dr. Allen will talk about that in a moment. And we have one, the South African variant, has been identified as well. So these cases have been spread over 11 health units, so it's not just localized. A number, of course, were attached to the outbreak at the Roberta place in Simcoe, but they're not the only place that has them. And that's an important thing to understand and to look at there. So I'm going to ask Dr. Allen now to talk about the variants and whether she wants to comment on that, as well as the so-called point prevalence study, which I think is very valuable and very informative. So over to you, Dr. Allen.
Thank you very much, Dr. Williams, and thank you for the chance to present some of these results. As a refresher, there are three main variants of concern that are being followed internationally. The so-called UK variant, or B117, the South African variant, or so-called South African variant, the B1351, and the Brazilian variant, otherwise known as P1. All three of these have significant numbers of mutations as well as evidence of clinical and public health impact. There is the likelihood that there will be other mutations and other variants that will emerge over time, and the purpose of this study, though, was to focus on those three variants of concern and is complemented by other work which I will describe at the end. Public Health Ontario collaborated with multiple institutions, including the Ontario COVID Genomics Network, the Provincial Diagnostic Lab Network at Ontario Health, and the Science Table, to design a study where we could look at a point in time and what the prevalence of these three variants of concern were in Ontario. Using a test developed in Ontario by colleagues at Public Health, it is a screening PCR test that looks for specifically one mutation, the N501Y mutation in the spike protein that is characteristic of all three of those variants of concern. The study was performed on January the 20th, and all samples that were reported on that day were requested to be submitted to Public Health Ontario for screening, and if it was screen positive for that mutation, was then referred on to whole genome sequencing for confirmation. The interim results are being presented today, and final results will be available next week, but all of the efforts are to be able to inform decision-making in real time, and hence bringing these interim results to you. So of the expected over 3,000 samples reported that day, 1,880 samples are included in this interim analysis, and 5.5% of all of these 1,880 samples were screen positive for the N501Y variant. The majority of these, unfortunately, were from a single outbreak that Dr. Willams had described earlier at Roberta Place. And looking at community cases not associated with outbreak, it represented 1.2% of the remaining samples. There was considerable variability across public health regions, with over 6 health units with cases identified in this interim analysis, and Simcoe Muskoka District Health Unit was represented because of the cases that were discovered at Roberta Place. In Toronto, 5 of 301 samples tested positive for a variant of concern, and in Peel, 6 of 403 samples were positive. To further support the effort to identify variants of concern, on February 3rd, we instituted routine screening of all positive samples for the variant or this mutation 501 mutation. This is already underway, and routine reporting will be starting shortly in the coming days. To complement this, we are partnering with multiple different organizations to also sequence or samples that do not have this mutation, so that we have a concurrent strategy for looking for emerging variants. While these data may suggest lower prevalence, it does highlight the unfortunate circumstance of the outbreak and how quickly this variant spread. And also, we recognize that the doubling rate of this variant has been shown in modeling studies to be quite high. And essentially, a doubling is expected approximately every 1 to 2 weeks. Therefore, data in the coming days will be helpful to understand how this is evolving in the Ontario context. With that, I'll pass it back to Dr. Willams. Thank you.
So, as Dr. Allen knows, this is very important to have the prevalence study. We're the first to do this on a large volume of samples in a day. And as Dr. Allen announced, that starting on the 3rd, we're going to be having all our positive PCR cases vetted through this process. This means Ontarians and ourselves, the public health community, and Ontarians writ large will have a very much real-time update on what is happening with the variants in Ontario. The sequencing, if you're using the other process of gene sequencing, I know Dr. Allen admitted it, but it does take a long time to undertake to do. It needs to be done. It's costly, and it takes a while, up to a week or 2 minutes, sometimes 2 weeks. So it's not as rapid in that sense. So we'll have more, I would say, closer to real-time assessment of that. We're also, any positive identified at our airport screening program are also being moved over to PHOL for the vetting through the 501 mutation finding. And our other screening programs, if we find them in positive tests with PCR, they'll also be added into our total. So this gives us a dynamic combination of screening, and sometimes people misunderstand what that means. They are moved quickly into diagnostic with our PCR testing. Those PCR tests then, if necessary, or they all will be vetted through, if they're found to have the 501 mutation through our PCR that Dr. Allen's team has developed, they will then be taken through the sequencing to identify definitely which variant it is, and that will keep us informed, the public informed, and our decision makers informed of what's happening. Why is it important to do a point prevalence study? The question we have to ask ourselves, and people saying, well, how much is it around? How much are you seeing? And so going back on the 20th, we looked at and said, okay, now we know, as Dr. Allen's alluded to, it seemed to be about 1.3%. What does that mean? So it's saying, oh, well, it's only 1.3%. It's not an oh, well. We go back. We knew that it was circulating before Christmas in there, the UK in particular. So we've asked Dr. Brown and his team to take that data, which is only but helpful, vet that through their analytics, and we're hoping to get a report from him to say, what does that mean? Because, as you heard Dr. Allen saying, it can double quite quickly. And I think what we're seeing is that, as I said before, the steps taken on Boxing Day and on the stay-at-home order has brought our numbers down, that's true, but it's also constrained the transmission and the doubling of the variant. And so this is important to note, and we want to have Dr. Brown walk that through and saying, is that true? What does that mean if we didn't have this, if we do this and different steps as he's done before? So we're hoping to have a report coming on that in the future. It just tells you how important our stay-at-home order and the order on the 26th of December have been in regards to that. At the same time, people asking about the variant, and Dr. Allen will say the same thing. It's still, our spread is still through droplet. It's still our measures of masking, proper masking, wearing a proper mask, not hanging down half down your face, the 6-foot distancing, household contacts only, washing your hands. If you're sick, get tested. If your app's gone off and alert you, get seen and get tested. If you've been asked by public health to go and get tested, do get tested. If you have concerns about it, talk to your public health department in that regard and have it tested as soon as possible. So what we said before was important for the COVID-19 writ large. Now for the variants, it's even more important to be vigilant in what you're doing. Be careful and cautious if you're out in public settings, because we've seen from the reports from the UK that what we thought was maybe get away with a 10 to 15 minute talk with someone 2 or 3 or 4 feet away without masking. Certainly with the UK variants, that's not the case. All you need is a short exposure for a short period of time with someone you don't know at all, without mask and protection, is a risky exposure. So you're going to have to be even more careful and cautious as you go forward. They still work, but you're going to have to do it well, do it better, and do it consistently. So that's where we are at this time. And with that, I'm going to open up for questions from the media. So thank you.
We'll go to the phone lines. Just a reminder, 1 question, 1 follow-up. Over to the first question, please.
Your first question comes from Ashley Legasic from News Talk 1010. Ashley, please go ahead.
Hi there. I hope you all can hear me all right. I was just wondering, doctors, do you have any projections by looking at these results of how many cases of the variant may actually be circulating in the province?
Well, that was the question. If you take the point prevalence back on January 20th on a go-forward basis, because Dr. Allen and the team will be testing every positive case. And so that means we will get almost a regular update of what that is, and we'll have almost like a daily percent positivities as we get the system rolling. So we'll have some live time on that. That's also, I asked Dr. Brown and the modeling team to take it, understanding the metrics of what they learned, at least from the UK, which has more data than some of the other variants, and understand where we were in December, where we are on the 20th, where we are today. What are the projections on that? Because it's all impacted by our public health measures. What are you doing and how much impact is it having? What happens if you change those? What are the potential impacts on that? So we're going to get back to you on that. So it's a very important question, and one I know that Dr. Allen and the team will be able to give us much more, in a sense, real-time, not real-time at the moment, but as much as our daily reporting, and we might assimilate that into our data and our reporting methods on a go-forward basis. So this is a tool, and due to our technology and the expertise of our lab here, Public Health Ontario Laboratory, that no other province has at this moment. So we're hoping to utilize it in the way you're asking for at the moment.
Follow-up?
Thank you. And Dr. Williams, you touched on this as well, and Dr. Brown has said previously that the key to limiting transmission and spread of the UK strain would be keeping up public health measures. And there has been a lot of chatter about reopening the province recently. So what do you think should be done? Should we start to open up or should we wait longer?
As you can see with all this data that's moving around right now, with our numbers changing, with our volume, our percent positive changing, at the same time, the mutations, the variants coming up, we're in a very, as Dr. Brown said last week, a precarious situation. And so we are trying to look at those numbers carefully. We're putting all those extra measures into saying on Monday we're opening up 13 of our 16 remaining health units on Monday, and then the following Tuesday after Family Day, the other three, York, Peel, and Toronto. And so these are changing. We have said we don't think that we're really strongly believe that with the measures in place, the extra ones that Minister Lecce announced, we announced, that will not have an impact on community spread. Yet, the amount of community activity still has a potential impact to come to our schools, and we're putting all these extra screening, testing methods in place in there. So we want to see what that's going to do. We have our vaccination program that's also slowly slowed down a bit at the moment, and is going to pick back up again. We would like to not have the slowdown, but it did occur, and that's beyond our control. But we're going to step back up into that. So there's a number of different things moving that we want to assess before we make recommendations further. So the school opening is not the same as the other one. They're independent. And we've been trying to drive towards getting our schools open, much like keeping our long-term care open to essential visitors, which we feel is very important. And we've kept at that task and set up different methods of screening and testing there that we're doing live time. Schools are just as important for the development of our children. As I said, we want them to open. We've done in phase-wise to stay open and keep open. And so we're putting that forward. So I think you have to stay tuned. We'll have more updates as we have more data and information.
Next question.
Your next question comes from Anthony Fury from Post Media. Anthony, please go ahead.
Thank you. Dr. Willams, as we see cases drop not just in Ontario but in a number of jurisdictions, I notice there's increasing conversation among some infectious disease experts about the idea of seasonality. Can you tell us your thoughts on how seasonality is or is not playing a role in Ontario right now?
Yeah, seasonality, it's a discussion. I know our science table has looked at some aspects there. We have seen that we did go down to very low numbers in our summer. We've known that some of our other viruses seem to have a seasonal aspect. There's aspects that you hear the term innate immunity wanes in the winter months to some extent, and you get some more cases. This is usually when you have a lot of other respiratory viruses. It's very interesting, in fact, fascinating to me when I just got a report back again from the national database on we have a amount of our influenza viruses, our other viruses, ones like the fancy names adeno, rhino, RSV. I won't go into all the details. Usually this time of the year we have a large number of tests being done. We still have lots of tests being done, but we post big numbers. And we usually have big numbers of influenza A, B, parainfluenza, lots of rhinovirus, everything. Again, I looked yesterday, across the line for the last week for A and B, influenza, 0, 0, 0, 0. Across the line for the other viruses, mostly zeros except for some rhinoviruses. And those are even small. I have not seen that in my time. And so there's a lot of people who said, you used to get a cold every winter. I seem to be doing okay at the moment. And so we see this number has been lowered. With seasonality, it should be high. But with all the protection and masking that, it tells you it's having an impact, not just on COVID. It's having an impact on these other respiratory viruses, which are transmitted person to person, droplet spread, coughing on people, sneezing on people. That's why we've had all those messages in the past about coughing in your sleeve and all those other things there. These have had an impact. And that's when a season when we should have a lot, but we're not. So I don't know whether, Dr. Allen, you want to talk about seasonality? No, probably not. Anyway, so I think it's a good question. We keep asking our scientists those things. And but our data tells us that has sort of changed the shape of that, even this, as we look at these reports. So it's been quite amazing to witness this.
Follow-up?
Yeah, on a related note, and I know the sort of theme of your presentations today was on these variants. When we talk about other jurisdictions having a major drop right now, two of the countries that are places of origin for variants, the UK and South Africa, they're having a major drop in cases right now along the same timeline as Ontario's. What should we make of that when it comes to those variants coming here, the fact that those countries are dropping right now as well.
I'm going to make a comment. I'm going to ask Dr. Allen to comment. I mean, we call this the UK variant. We call it the South African variant. That's not the only source of where these come from. And I'll ask Dr. Allen to comment on that and how these get titles and names and stuff like that. And, I mean, you have to look at other variables like the UK. They're doing a very large mass vaccination program with their own domestic products and different things and that. So there's other variables that play into their drops and numbers that a little hard to compare with in that light. So, but I think it's important for Dr. Allen probably to clarify these titles and names and what does it actually mean as far as the transmission and where they're found.
Next question.
Oh, no, Dr. Allen's going to answer the question.
Sorry. Thank you very much, Dr. Williams. As I think what's important to know is that UK is actually one of the world leaders of whole genome sequencing. And in fact, the ability to case find is a signal of the strength of that system. Similarly, the P1 Brazilian lineage was identified in Japan, which again has a very robust sequencing ability. I think it's an interesting question about, what is the appropriate level of concern around the variants of concern and what can we expect to see going forward. And I think the results from the modeling table will be extremely helpful. But I do think it warrants some caution. As we know, we do have very strong evidence that it's more transmissible. So again, re-emphasizing the importance of all of the physical distancing measures where they can be arrived at, all of the other both system level measures and individual level measures to be able to curtail the spread. So I think that continues. We continue to learn more about these variants, and again, it's having enough information in real time, both in terms of what the prevalence is in the province, and also as we understand better how it behaves in other jurisdictions. I don't find it surprising that the rates are going down in the UK. I think we do know that the same measures are effective. And I think it's really important that we continue to work towards the end and see as much of what's going on as we possibly can as we go forward. So thank you.
Next question.
Your next question comes from Kate Allen from the Toronto Star. Kate, please go ahead.
Thanks. My first question is for Dr. Williams. At the modeling briefing last week, Dr. Brown said that Ontario's effective reproduction number should be at 0.7 to withstand the increased transmissibility of B117, and Ontario's is currently at 0.84. So reopening aside, I'm wondering how confident you are that the current slate of public health measures is adequate to suppress the transmission of this variant, especially with schools returning.
So the so-called RE or RT, you hear the terminology. It's an interesting one to calculate, but we trust our modelers to put that data together. In the peak of when we're in the Christmas, New Year's holiday season, we were well over 1. We're up to 1.1 at times, which means that for every person you're infecting more than that. The fact that we're under 1 is very encouraging. We moved under that, 0.89. We're down a bit more. As the numbers keep dropping, it tells you that it speaks to me that our measures have been effective bringing that down. And we've seen that while we didn't see a lot of improvement in our first few weeks after, because you need about a 2-week period, after the Boxing Day one was put in, we started to see more effect in about the 3rd or 4th week before we had the effect of the stay-at-home. They have compounded and added to each other. And so I think we're seeing this fairly I would say fairly good progression. That is a lot quicker than I would expected, but we're not out of there because it tends to come down in little plateaus. It never goes on a straight line down. So we're going to watch that. So I think getting down to 0.7, that would be really reassuring. That would mean our numbers would be down a lot lower than they are now. But even since our last report with the 0.84, we've seen our numbers over the weekend and this early part of this week to come down even more assertively throughout the province. So all positive. And I think it just speaks to me of the effect of the measures. And the people of Ontario staying the course and doing what they need to do. So the measures, and we need everybody to do it. And as Dr. Allen's alluded to, these same things, it's not complicated. You just have to do it again, do it well, do it consistently, and be careful. in avoiding any contacts outside of your household.
Follow up?
Yeah, I think this is probably a better question for Dr. Allen, although either of you, I'd welcome an answer from either of you. So you noted that the burden of B117 is not distributed equally, that some health units have more cases of the variant than others. And I'm wondering if there are any strategies for extra surveillance or sampling in those health units. I know you're screening all positives, but of course you can only screen the positives that you get. So is there any other surveillance, testing surveillance being implemented in some of these health units?
Yep, thank you. I think the point is very well taken. One of the key points of all of the variant screening and the whole genome sequencing is making sure that it's very, very closely linked with the health units and their work. And so when there was, currently the effort is to do a much deeper investigation or prioritize the investigation of the variants of concern, and to do that very rapidly. There's been a lot of collaboration across the sector. So I can't say that there to date has been increased screening of those neighborhoods as a discrete effort around the VOCs, but there has been a deeper investigation of any potential cases and ongoing screening. There is concurrently a great effort to increase testing overall in all sorts of modalities that has been described by Dr. Willams, both in terms of moving out more of the rapid testing and to make the PCR-based testing, the lab-based PCR testing more accessible. So those are the efforts underway. Thank you.
Last question.
Last question comes from Randy Rath from CHCH TV. Randy, please go ahead.
Hi, doctors. I'm wondering, with the bars being closed because of the lockdown, are you concerned that private residents, Super Bowl parties and private residences will become spreader events this Sunday?
So, Randy, I think this Sunday you're referring to the sports event. Well, we have our aspects in place already around gatherings. Those enforcement aspects, even before the stay-at-home order, are still in place, including reporting and using peace officers to investigate and charging individuals who violate that rule, both the organizer with a hefty fine and individuals as well. So that has not been lifted. I think people can still have virtual parties, especially with different methods and tools where you have not just 4 or 5 people you used to gather with. You can have 40 or 60 people on if you want with a Zoom party and do it quite safely that way. And people have been very creative with their technology, and I applaud them for that. So I think there's safer ways to do that in there. So and plus, the other thing it means that people, I think what you're inferring, are not drinking and driving afterwards, and they're staying in their own premise and location. So I think there's a number of safety added benefits of doing it virtually. We require that. It's still not allowed to have those gatherings, just household. But I think there's ways technology can really enhance that and still make it a fun event and safer. And I guess I'm very concerned also with people who would be drinking and driving, and that's very concerning as well. That message has not gone away. That's still a solid message. So would be my comments to that.
Follow up, and this is the last question.
Yeah, we have contacted a major pizza chain and a major sub chain, and we told them we're going to have a party with 30 people at it for Super Bowl Sunday, and asked them if they could help us with food, and both of them said, yeah, absolutely, no problem. You'll need, 7 giant subs or 6 giant pizzas. I'm wondering if there's anything that you can do should there be an onus on companies to not fill orders that are clearly going to be used by more than the members of a household? And is there anything that you can do to prevent that from happening?
Well, we want those companies not to do that. I've had some who said, we're going to have, I'm going to host a virtual party. there's 30 people, and I'm ordered stuff for them to be delivered to each of their households. And that can be done. But I think I would say if you're having a party with 30 people congregating, I'm not sure how that would work. I mean, if someone said, well, we're going to go around and we're going to drop off at people's doorsteps the stuff and go around beforehand, not congregate together. So I don't know the details. I know people have had different ways to try and help out in that way. Sometimes there's people, especially some older people who are shut in, and they drop off food at their location to have them be able to take part. And with proper distancing and doorstep drop-off and notification, there's ways you can still do it, still be hospitable, and to share, especially those who normally can't get out and do that. So I think there's lots of areas in there. So whether maybe some, as you're alluding to, some perpetrators of that, I think most are trying to be very careful on that, and I would certainly encourage those safety precautions to be put in place. And yet at the same time, those who are not able to get out and shut in, help them out by dropping something off. There's nothing wrong with that, with the proper steps and precautions in there. So if your generosity and hospitality, do it in a safe way. It can still be done. And just manage all the precautions that we've talked about in that light. And just be very careful and do it because you want to be careful and protect them while you're having an event, and then have a virtual connection and enjoy the activity, whatever you're doing, virtually. It can be done very safely.
Thanks, everyone.